Welcome to BiteMedicine's 91st webinar. So getting close to 100. It's also our 1-year anniversary as well. So, you know, it's great to celebrate that big milestone with all of you today. For those of you who don't know me, my name's Azim. I'm one of the co-founders of BiteMedicine. As I said, we've been running these webinars for most of them for free, actually, for a year now, just over a year. And it's been an honor and a privilege to teach you throughout lockdown, people all around the world, and it's been really, really fantastic. So we are continuing our differentials series. I think you've covered shortness of breath already with, I think it was with Schwabe, and today is abdominal pain. So before we crack on with that, I just want to make sure that you can see my screen, the main screen, hopefully, and you can see and hear me okay. If that's all good, we'll press on. If there are any issues, just let me know in the chat or in the Q&A, and yeah, we'll make a start. So as always, we are using our kind of multi-step SBA, or today really we're going to be using a normal single best answer system with interactive questions on Mentimeter. We're going to be going through various key differential diagnoses for abdominal pain. I've said 70 minutes. I hopefully suspect this will be 60 minutes. But just to be safe, and of course for our clinical year medical students and physician associates as well, all around the world, but obviously based on UK guidelines at the moment, and also take some questions at the end. If you have questions as we go along, just pop them in the Q&A, and I'll try and get around to them as soon as I can. But without further ado, and before we jump in, actually, well, I'll just make sure that you're all aware of our question bank, online textbook, live webinars. We've got a new upload coming out, I think, tomorrow with some new features as well as some new topics. So do check out our multi-step SBA based on the most recent evidence in medical education to improve your retention and your knowledge, as well as our online textbooks, with textbooks being updated every few days and new textbooks being added. And if you want an extra discount to get access to absolutely everything, then you can use my promo code Azim2021 for an additional discount as well. So it's a competition between, I think, Schwabe, Rich, and I. So I would love to win that competition, but also you get some money off as well. So feel free to use that if you'd like for premium access. So let's crack on, and we'll be talking about abdominal pain today, and we'll be working through our key differential diagnoses, kind of medical diagnoses, surgical diagnoses, vascular, urological, all sorts of things. And obviously, abdominal pain, there are a vast number of different differential diagnoses. So the key here, as I'm sure you know, at BiteMedicine, it's going to be simplicity, it's going to be the high yield facts, and to really help you knuckle down to figure out, when you see a patient with undifferentiated abdominal pain, how you're going to approach these patients. So I've put this diagram here that we've made, and this is kind of a similar approach we're going to be using. Is we're split it into quadrants rather than, you know, lumbar region, hypochondrium, and iliac fossa, just to keep things straightforward. But it's going to be very interactive. I'm going to be asking you guys questions. We'll be going through interactive questions on Mentimeter as well, but really taking you from the absolute basics and working our way up to more complex diagnoses as well. So it's all going to be case-based. I think we've got 10 cases in total, and I'm trying out some new features in our webinars as well. So keep an eye out for those. But like I said, we're going to split into quadrants. So right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant, and then epigastric and periumbilical pain as well. So those are the key areas we're going to be looking at today. So as I'm sure you're all aware of, and you know, you've all probably heard this acronym Socrates. You know, I'm several years post-graduation, and when I see patients with abdominal pain, I might not think of Socrates directly, but when I look back on the history I've taken, you know, in all cases, I've covered all of these key points. So, and it's these areas and these questions that you're going to ask that are really going to help you figure out the cause of this patient's pain. As I said, lots of organs in the abdomen, lots of causes of abdominal pain, some even above the diaphragm that can cause, you know, upper abdominal pain as well. So you need to know your anatomy, and you need to know what types of pathology cause what types of pain and where. So that is the stuff we're going to be talking about. But make sure you're aware of Socrates, and we're going to be tying it all in today as well with these kind of key aspects and key questions that you'll be asking. So let's crack on. Let's talk first of all about right upper quadrant pain. So as I said, we've split it into quadrants. So when we say right upper quadrant, we can also be talking about kind of lumbarish region as well. So let's think about our first case. So we have a 45-year-old female who presented to the emergency department with severe, constant right upper quadrant pain and feeling hot and sweaty. She's vomited once, and she's had several episodes like this in the past. So hopefully a nice straightforward one. You're already kind of thinking, you know, what could be causing this patient's symptoms. And these episodes in the past, particularly after she eats her favorite meal, which is a double cheeseburger with fries. I also love a naughty little double cheeseburger with fries, so I can relate to that. However, today she feels particularly unwell. Have a look at those observations. What do you all think about those obs? Are we happy, unhappy, and why? What kind of things are abnormal here? You can just pop it in the chat. Good. Pyrexic? Yep, 38.8. Unhappy, good. So tachycardic, pyrexic. You've got a systolic of 100. So, you know, things are not looking great for this lady, and we need to intervene, try and figure out what's going on and treat this lady. Definitely agreed. So let's go on to this question. So this question is going to be on Mentimeter. So just, like I said, a nice, straightforward one. I'm going to try and share this screen now. So hopefully you can see Mentimeter. So I know I can see some of you answering in the chat, but for these questions, if that's okay, if you could please make sure you answer on Menti as well, just so we can have a bit more of an interactive approach. So hopefully you can all see Mentimeter now. And if you go to menti.com, you can see the code there at the top. So menti.com, and use that code 62123794. And we can answer this together. So for these Menti questions, make sure you answer here rather than in the chat, just so we can keep things more interactive. So some of you are saying, most of you are saying cholecystitis, but as I expected, a little bit of a split between cholecystitis, cholangitis, biliary colic. But the majority of you are absolutely correct. This is cholecystitis. And if you're unsure why, and you're not exactly sure why we've gone for that rather than a couple of those other options, well, here is your explanation. So you've got this patient here with right upper quadrant pain and fever on the background of this intermittent right upper quadrant pain, which is highly suggestive of a history of biliary colic. So she likely has gallstones. But now she's got a little bit of infection and inflammation of her gallbladder, and now she's got cholecystitis, which is just that inflammation that is taking place of the gallbladder. It's not cholangitis, because cholangitis, you would expect a patient often to have jaundice, or their bilirubin will be raised as well. But in this case, there is no real suggestion that this patient is cholangitic, and this patient is systemically unwell. So this is most likely going to be cholecystitis. I will pop the Menti code up when we get to the next Menti question, so don't worry about that. So these are the key features of the history suggestive of cholecystitis. This history of right upper quadrant pain after eating a fatty meal is very suggestive of biliary colic. As your gallbladder contracts to release bile, then that is the pathophysiology taking place here. And now she's got infection, inflammation of her gallbladder, and that is why she is now hot and sweaty, vomiting with right upper quadrant pain, and that is cholecystitis. Hopefully that makes sense to everyone, and everyone is on board with that diagnosis there. So we've already talked about all of this. So biliary colic is often this recurrent right upper quadrant pain after fatty meals. That's kind of the characteristic history. Cholecystitis, you get fever, and a positive Murphy sign as well. So we have a whole webinar on colic and cholecystitis, so do check that out. Whereas ascending cholangitis is Charcot's triad. That's the thing to look out for: right upper quadrant pain, fever, and jaundice. And that's why any patient that you suspect has cholecystitis, you must, of course, check their bilirubin levels, because if they're hyperbilirubinemic, then you're thinking this is going to be jaundice. Sorry, this is going to be ascending cholangitis even. And then also this obstructive picture you would expect with dark urine and pale stools also in ascending cholangitis. The first line investigation for these patients is going to be an abdominal ultrasound, a transabdominal ultrasound. And if you're thinking there's a stone in your common bile duct, then these patients with ascending cholangitis are going to need an MRCP, basically a specific type of MRI scan. But as I said, look back on that webinar, and hopefully this will make sense. But well done. The vast majority of you said cholecystitis for that question. Nice. So thinking a little bit more about right upper quadrant pain now. So a 45-year-old male has presented to the emergency department with right upper quadrant pain and chills. He's currently of no fixed abode, which means, in other words, he's homeless, and on most nights he sleeps in the city center. He's not registered with a GP and is uncertain of his past medical history. As you can see, you look at his hands, they're quite dirty. You open his bag, you see some of these pills, and you also find these needles in his little plastic bag that he's brought with him to A&E as well. So those are a few things that you find. As you can see, his observations here, he's tachycardic and he's pyrexic as well, with a temperature of 38.2. So let's head back over to Mentimeter. Hopefully you've got that history in your head. You know, some alarm bells are ringing for you there as well. Let's pop back over here and answer this question together now. So hopefully you can all see this. What do we think, which investigation is most likely to reveal the underlying diagnosis? I'm just going to have a look at the Q&A quickly. Is it true that for Murphy sign to be positive, you need the left side to be negative? Technically, yes, that's what people say. In reality, it's quite straightforward to elicit a Murphy sign on the right, and then it's very unlikely for it to be negative on the left. But yes, technically, that is what they do say, is you should try and elicit on both sides. And yeah, like I said, pop over to that other webinar on cholecystitis and you'll get a little bit more of an insight into Murphy sign as well. So most of you, once again, have gone for one specific option. So in this case, most of you have said viral hepatitis serology is most likely to reveal the underlying diagnosis. And you would all be absolutely spot on. So nice. So let's head back over to that history of this chap here. So remember, we opened up his bag and we found little bits and pieces there, didn't we? And we found some pills, we found needles, and you know, he's of no fixed abode, right upper quadrant pain and chills, is highly suggestive of a viral hepatitis. So most likely due to hepatitis C secondary to intravenous drug use. So yes, you would expect liver function tests likely are going to be deranged, but if we're thinking about the underlying cause, it's most likely going to be that viral hepatitis serology that you're going to need. So hopefully that makes sense to everyone. And these are the key things in the history to be aware of. And this is why it's so important as well that you really inspect the patient peripherally. You know, you get their permission, you ask, you know, can I have a look at, you know, your medication list, whatever else is in your bag, if they're happy for you to take a look. Particularly in patients with a background like this, it's always useful to get little other bits of information that can help piece together a potential differential diagnosis. So in this case, that right upper quadrant pain hepatitis, which is just inflammation of the liver, lots of different causes of hepatitis. I'm focusing on viral hepatitis here. Patients often present with a little bit of right upper quadrant pain because of that inflammatory process going on. They may be jaundiced with evidence of decompensated liver disease, so things like confusion secondary to encephalopathy. They could have ascites, for example, if they have kind of later stage liver disease. And it's important that you assess for those risk factors for viral hepatitis. So intravenous drug use, you know, characteristically things like tattoos, HIV, blood transfusion. These are the types of things you may consider asking about if you think it is appropriate. And the key tests, obviously there are lots of other tests you would do for these patients, but the key ones, if we're thinking about viral hepatitis, are going to be liver function tests and your viral hepatitis serology. So things like your hepatitis C virus antibodies would be a useful test, but your full set of serology would be useful. But as I said, lots of different causes of hepatitis, including, you know, lots of causes of chronic liver disease, including alcohol, autoimmune causes, non-alcoholic fatty liver disease. But in this case, we're thinking specifically about viral hepatitis here. So good. A little bit more in depth on right upper quadrant pain now. So let's have a think about this, this lady. So 33-year-old lady has presented to the emergency department with an 8-hour history of right flank / right upper quadrantish pain associated with pain passing urine, a fever. She's vomited twice. As you can see there, she is lying in bed looking pretty uncomfortable. She has a history of type 1 diabetes. As you can see on those obs, tachycardic, and with a temperature once more. Those are probably the big abnormal things there. So digest that history a little bit, have a deep think about that, and we'll head back over to Menti. Which of the following is not required for this patient in the immediate term? Which of the following do you think is not going to be needed in the immediate term for this patient? Yeah, there's a code at the top there if you need it, but thank you for people in the chat also putting the code there. Good. CT, abdomen, and pelvis with contrast. Agreed. That's really the one thing we don't need here. Just in the chat, what do we think is going on with this lady then? Pyelonephritis, pyelo, yeah, good, good. Absolutely, I'd agree. This is likely pyelonephritis, which is kind of essentially just an infection of the kidney. So you can get a simple lower urinary tract infection that can then ascend up your ureters, up towards your kidneys. And pyelonephritis is just inflammation of that upper urinary tract. So obviously she's type 1 diabetic. So, you know, also in the back of your mind, we should probably check ketones for this patient, check her BM, make sure she's not in DKA secondary to this infection as well. So it's important that we also think about these patients' other comorbidities as well. So definitely, you know, you don't want to, and absolutely beta HCG, spot on. Thank you. Absolutely a really important thing. And that's what you would do alongside your urine dip. These patients all need pregnancy tests, 100%. But yes, in suspected pyelonephritis, you're not going to need a CT abdomen and pelvis. It's often it's going to usually be a clinical diagnosis. You may consider an ultrasound to see if there's other kind of upper urinary tract abnormalities or potentially like an abscess or something else there, but often it's just a clinical diagnosis. These patients are admitted under the medics. So that should say U's, not UNS. But of course, you know, get your urine dip, look for white cells, look for nitrites. You may have a little bit of blood. Get your pregnancy test as well. Get your renal function. Once you're confident this is just a simple pyelonephritis, you know, admit under medics, and of course manage with fluids, antibiotics as per your local guidelines. Good stuff. And of course, this is why we think it's pyelonephritis. So that right up, so obviously you can get pain on either side of pyelonephritis because you have two kidneys. But in this case, it's a right-sided pyelonephritis with some lower urinary tract symptoms, tachycardic, pyrexial. But of course, check pregnancy test, check blood glucose, check ketones as well, particularly as she's type 1 diabetic. Good. And yes, type 1 diabetes can increase the overall risk of infections, particularly if it's not managed correctly, and you haven't optimized their medical management. So here are some key causes of what we've talked about already. So we've talked about some biliary ones, liver ones, and some renal ones as well. So hopefully we've taught you understand a little bit more about these. Renal colic is an important one to mention as well. We haven't got a case on it, but remember, if you've got renal colic, you've got a stone somewhere. It could be nearer the pelvis of the kidney. It could be in the ureters, for example, and you can get or kind of loin to groin pain, which is really severe, colicky, kind of worst pain. Patients can hardly sit, well, they have to sit still because the pain is so bad. And then all of the, in patients with renal colic, we diagnose now most commonly with a CT-KUB, so that's a non-contrast CT kidney, ureter, bladder. But also important to think about other causes of right upper quadrant pain as well. So that's stuff above the diaphragm, so things like right lower zone pneumonias, for example. This is not an exhaustive list, just a few really key ones that you should always assess for in the emergency department. So hopefully you've got a better understanding. Someone's asked me how you do differentiate between pyelo and renal colic. Pyelonephritis, most commonly, you're going to have maybe often some degree of lower urinary tract symptoms like dysuria. You're going to often have a fever. You're going to be, a bit more of a dull ache rather than really severe spasmodic pain. So that colicky severe pain is going to be renal colic. If you have really colicky sounding pain and a fever, it could be a stone with superimposed infection, and that's a urological emergency. So, it's important that you consider both of these diagnoses, because you can obviously have renal colic and have an infection on top of that, and that may need things like nephrostomies and drainage as well. So, have both of these diagnoses and differentials in your mind as well. Good. So let's move on now. I know this is a bit of a whistle-stop tour, but let's move now on to left upper quadrant pain. The good thing is that we've already covered a few of these causes. Now, we have two kidneys, of course, and that's why we can also lump pyelonephritis and renal colic back here into that left upper quadrant. So that's less kind of lumbarish pain, so pain in the lumbar region. That once again, that left lower zone pneumonia as well might cause that left upper quadrant pain. So look for things like productive cough, pleuritic chest pain, shortness of breath, those types of things, and get a chest x-ray if you think this is actually a lower lobe or lower zone pneumonia. And similarly, myocardial infarctions or essentially heart attacks can present in odd ways sometimes. And sometimes the pain is a little bit lower down. I know we all learn that central crushing chest pain, but you can get kind of atypical sounding pain as well. So get your cardiovascular risk factors, make sure you know what they are for the patient, and get ECGs. I get an ECG on any patient with upper abdominal pain, every single one. Because if you're missing a massive STEMI, for example, because the pain is slightly atypical, that's your that's your license, which is going to, and that's your name that's going to be on that documentation. So always get an ECG in patients with upper abdominal pain. Really, any patient that's going to be admitted is going to have a baseline ECG anyway, but it's those life-threatening conditions that you really need to look out for and pick up really at the front door in A&E. Good stuff. So thinking again about left upper quadrant pain now. So you have a 28-year-old male who presents to the emergency department via ambulance following a road traffic accident. You perform a primary survey, which is that A to E assessment that all patients get when they come to A&E, particularly those with trauma. You perform that primary survey, and on examination of the abdomen, has severe pain in the left upper quadrant. No other obvious injuries are found, and those are the patient's observations. Just in the chat, what do you all think is the most likely cause of this patient's presentation? Spleen rupture, spleen injury, shock. Yeah, the patient is definitely in shock. Internal hemorrhage, bleed, good. So absolutely, I think you've all, really everything you've said is absolutely spot on. Patient is in shock, likely hemorrhagic shock. Internal bleed, so some bleed below the diaphragm, so abdominal bleed. It could be a diaphragmatic injury, but you're absolutely right, most likely going to be a splenic injury / splenic rupture. And the spleen bleeds out, and these patients can die. So often that's why a primary survey is so important, because you need to pick up on those life-threatening injuries. And as you're all saying, the spleen is the most likely thing, but also things in this kind of lumbarish zone and upper quadrants, for example. If there's a really severe injury, you can get, your kidneys can be affected. You have renal injury, you can have diaphragmatic injury, you can have splenic injury, you can have injury to the tail of the pancreas. But in this case, I agree, it's most likely going to be a splenic injury. I mean, that's a bit of an unfair question because not all patients are managed surgically, actually. Here we go, but a proportion of them are, but it's kind of dependent on your findings on imaging. So you grade your damage to your spleen or injury to the spleen based on your imaging findings. Mostly commonly kind of CT imaging is going to be used to grade these patients. So we suspecting splenic injury. So these patients that have trauma like this, once they are stabilized to some degree, so once this patient is more hemodynamically stable, we try and get them in the CT scanner. And you do often now what's done is a pan CT. So CT head, neck, chest, abdomen, pelvis. So really the whole shebang, because we don't want to miss out on major injuries. So a CT is going to be so useful once this patient is stabilized, because then you can grade your splenic injury based on those CT findings. And that will help determine which patients can be managed conservatively and which patients will need to go to theatre for surgical intervention. By the bedside, we can also do a fast scan, which is basically a jelly scan, which is done in cases of trauma, which can show kind of free fluid in the abdomen as well, which is essentially always abnormal. So that's a little bit about splenic injury, which is not really taught at medical school that much, to be honest. But I wanted to make sure that you're aware of it, because once you are the SHO or the physician associate working in resus, these major organ injuries, you must be able to diagnose, or at least have on your differential list. Good. So that's a little bit about left upper quadrant pain. Like I said, there are other causes, but these are really key ones that I would recommend having in the back of your mind whenever you see patients with left upper quadrant pain or left kind of flankish pain as well. So let's think now about epigastric pain. So case number 5. So we have a 44-year-old male who's presented to the emergency department via ambulance with severe sudden onset epigastric pain. He's vomited several times. There he is being wheeled into the ambulance. He's vomited several times, feels very thirsty. Over the last few months, he's noticed that his stools have been bulky and difficult to flush. He works at a supermarket, drinks half a bottle of vodka every day. And those are his observations. Now, I'm not going to ask a question yet. Take all of that in. And I will send us over to Menti again. Which of the following tests is most likely to reveal the underlying diagnosis? If we could please think or answer on Menti and not in the chat, that would be great, just so other people have the opportunity to answer without seeing the answer. Okay, so once again, you're all far too good. Really, really good stuff. I really love that you are piecing together aspects of these cases and not just thinking what's the most likely diagnosis, but also thinking the next step beyond that, which is what investigation is going to be really useful for that diagnosis. And that is a little bit of a deeper thinking than simply what is the diagnosis. I'm really, really impressed. Good stuff. And you'd be spot on, amylase. And what do we think is going to, why are we doing an amylase in these patients or in this patient? What do we think the diagnosis is? Good, suspected pancreatitis. Now, you're spot on, and I think I was expecting a couple of comments, which I've now received in the Q&A. So one of the comments I've received in the Q&A is entirely valid, which is, isn't lipase more specific than amylase? You're spot on. I think across the country now, lipase is slowly becoming preferable to amylase, but current clinical practice, amylase is still widely used. So that's why I've put this here. But you're right, lipase is more specific, or that's what studies suggest, that lipase is more specific for amylase, but in clinical practice, often amylase is still used over lipase, but I suspect that's going to change in upcoming years. And liver function tests, 100% you're going to need to do liver function tests, and they're likely to be abnormal, particularly given that alcohol excess. But in terms of the underlying diagnosis, which is what the question asked, amylase is going to be more useful, or lipase, of course. Why do we think this is pancreatitis? So pancreatitis, of course, refers to inflammation of the pancreas. Lots of different causes of pancreatitis, of which alcohol is one of the most common in the UK. If you all remember that acronym called Get Smashed, gallstones and ethanol are kind of right at the top there, and that's because they are the most common causes of pancreatitis. So do check out our textbook on pancreatitis as well, if you want to know a little bit more information, but they normally present like this: a severe sudden onset epigastric pain. If it's acute on chronic pancreatitis, they may have features of chronic pancreatitis on top of this. So the fact his stools have been bulky and difficult to flush suggests a chronic picture. Do we know what this is called here when the stools are bulky and difficult to flush? What is that called medically? Perfect. Steatorrhea. Thank you, Maruf. Thank you, AJ, Zain, Ashrini, all of you. Spot on. That is steatorrhea. Steatorrhea is a key feature of a kind of a chronic pancreatitis picture because of pancreatic insufficiency. Technically, this is likely acute on chronic pancreatitis, secondary to alcohol excess. If that's what you want, if you wanted to be really specific about it, that's what you would say. Nice. So, as I said, we don't have time to go through cases on all of these, but these are some really important conditions to consider when we're thinking about epigastric pain. So, pancreatitis, as we've talked about, is a history that we've just been given. Think about your risk factors. Things like Cullen sign, Gray Turner sign, these are more kind of textbook signs. I've actually never seen a patient with either of these signs, but they always seem to come up in exams. And they basically refer to bruising in various parts of the abdomen, so either periumbilical bruising or flank bruising. But in our textbook, we have some nice pictures on both of them, so do check that out. We're thinking about diagnosis. Of course, lots of other tests that we can do for all of these conditions, but amylase, lipase, and then consider some imaging if required, such as ultrasound or CT pancreas or CT abdomen. Now, peptic ulcer disease is a really important one for epigastric pain as well. The nature of the pain is slightly different. It's kind of described as kind of a burning or gnawing type pain. The history is often a little bit different as well. So these are just ulcers which are most commonly in the duodenum, but can be in the stomach as well. Duodenal ulcers are worse when you're hungry and relieved by eating. And that's because when you eat, your pyloric sphincter constricts, and therefore the duodenal ulcer is going to be less irritated, whereas gastric ulcer is going to be worse when you eat because you've got more gastric acid being produced and you've got more irritation taking place. So ask about that relationship as well, really important. And if you have a bleeding ulcer, then we're going to be expecting things like potentially nausea, coffee ground vomit, melena, for example. And that's why any pain will, any upper abdominal pain, particularly epigastric pain, I will always get an erect chest X-ray on these patients, querying perforation. Really, as a general, surgical doctor or general surgeon, any patient with abdominal pain should have an erect chest X-ray because you're going to be looking for that free air under the diaphragm, because that would suggest that a viscus has been perforated. So erect chest X-ray. Patients are going to need upper GI endoscopy. And then if we're thinking about kind of more stable patients as well, we can do breath tests, stool antigen, but often you can just do, you can test for H. pylori during the endoscopy as well. But once again, think about other kind of medical causes like myocardial infarction is really important, which can present atypically. Just looking at the questions once more, with peptic ulcer disease, would it be epigastric pain regardless of ulcer location? It's most commonly epigastric pain. But although we say that, a lot of different, like, for example, cholecystitis can cause a little bit of epigastric pain. But we're talking about characteristic symptoms. Characteristically, peptic ulcer disease, regardless of whether it's duodenal or gastric, will cause epigastric pain. I found some patients presenting with right upper quadrant pain having ulcers. Has it happened to me? Yes, absolutely. If we think, once again, this is just kind of thinking about more from a characteristic history point of view. Brilliant stuff. Brilliant stuff. So these are the key ones that I always have in my mind when I'm thinking epigastric pain in the emergency department. Now let's think now, moving a little bit lower in the abdomen, about lower quadrant pain. So right lower quadrant pain. So this includes our iliac fossa as well. So let's think about case-based discussion number 6. So a 19-year-old male presents to the emergency department with his mother due to a 3-day history of gradually worsening abdominal pain. The pain originally started around his belly button, has now moved towards the right iliac fossa. He's felt nauseous, has a reduced appetite, and feels feverish. Now, I'm not going to, necessarily patronize you and ask too many questions about the diagnosis, because I think from that history, it's a very characteristic history of the underlying condition. But let's think one step ahead of that. If we're thinking our top differential is X, what about a scoring system for that differential to help you kind of from an evidence-based point of view come up with your, or kind of support your diagnosis? Which of these scoring systems might help you? You are all fantastic. I'm actually so impressed. Like I said, thinking about a diagnosis is one thing, but going that one step further without being given the diagnosis is a really important skill to have, and it shows deeper learning, and that's what we're here for today. That's what all our webinars are about. So that is absolutely right. The most likely diagnosis here is appendicitis, and the Alvarado score is what we use for acute appendicitis. All the other scoring systems do exist, but are not appropriate here. Glasgow-Blatchford for upper GI bleeds. Glasgow score we would have used for our previous patient with acute pancreatitis. Alvarado score is for that acute appendicitis from this patient, which is appendicitis, just inflammation, infection of your appendix, and that migratory pain from your umbilical region to your right iliac fossa is very characteristic. Not all patients present like that, but make sure you examine the abdomen really carefully in these patients. Assess for Rovsing signs, so assess, palpating both iliac fossae, get a full set of observations, get your bloods, and really any patient, youngish patient with right iliac fossa pain, low-grade fever, and raised inflammatory markers, you're thinking right. You're thinking appendicitis. And these other scores, have bled and MELD, are also not appropriate here. But very impressed. Fantastic stuff. And as we said, these are the key reasons why we think that that this is appendicitis. So likely this patient is going to need to go to theatre pretty soon. Okay, so those are a little bit of points about appendicitis, a few signs there to be aware of as well. Now, sorry, hopefully you all had a read of that. In terms of, we still kind of call appendicitis a clinical diagnosis, but we do often, the most recent NICE evidence does say imaging significantly reduces your false negative appendicitis, false positive appendicitis diagnosis. So you go to theatre, you open the patient up, you get your laparoscopic kit out, you look at the appendix and it's not inflamed. By doing some imaging, NICE kind of does say that reduces that process of taking a patient to theatre and realizing actually it's not appendicitis. So we do advise some kind of imaging in the majority of patients rather than simply going via clinical diagnosis. But you can often strongly suspect based on a history examination and raised inflammatory markers. Now, next case, thinking once again about right lower quadrant pain. So we have this lovely lady here, 24-year-old female, presented to her GP with severe right-sided abdominal pain, but she's ended up, as you can see, in the emergency department. It's COVID time, so everyone's wearing their masks. So she tells us a little bit more about this pain. So the pain started the evening before, described as cramping and constant. She's been feeling dizzy, She's sexually active with a single male partner and cannot recall when her last menstrual period was. She's had pain relief and is feeling more comfortable. That's why she's sitting up in bed now, looking a little bit more perky. What is the diagnostic investigation of choice? You can just answer in the chat. Read the question carefully. What is the diagnostic investigation of choice? So I'm reading serum HCG, I'm reading ultrasound, transvaginal ultrasound. Eva's gone even one step further and said beta HCG and ultrasound. You are all right in that those two investigations are absolutely required. The diagnostic investigation of choice is a transvaginal ultrasound, but of course we are going to need an HCG on this patient. We're going to need a pregnancy test, so a dip, and we're also going to need a serum HCG as well. And that's because the most likely diagnosis in this lady is, if you tell me in the chat, what do we think the most likely diagnosis is? Ectopic pregnancy. Brilliant. Fantastic. So yes, an ectopic pregnancy is a gynecological emergency, or, obs and gynae emergency, and the diagnostic investigation of choice is a transvaginal ultrasound. So essentially, an ectopic pregnancy is just a pregnancy, an egg has got fertilized and that pregnancy has taken place in a location where it shouldn't have. That fetus then essentially continues to grow and grow and grow in the wrong place, and then can wreak havoc, cause life-threatening bleeds. So we need to manage these patients and refer them as soon as we possibly can. There are specific scoring criteria and criteria about which patients can be managed medically, which need to be managed surgically. So once again, look at our textbook on that and be really familiar with the Royal College of Obstetricians and Gynecologists guidelines on how to manage ectopic pregnancy, which is all in our textbook. So not all patients need to go straight to theatre. Like I said, it's very specific criteria, but good stuff. And why do we think this is an ectopic? Well, abdominal pain, which can obviously either be on the right or the left, constant. The dizziness suggests that it's actually ruptured, so that's that's a big red flag. She's sexually active and can't remember when her last period was, which suggests an ectopic pregnancy. Good. And that's your ectopic, a little bit more information about that. And of course, the key tests alongside all the others we're going to be doing is going to be a transvaginal ultrasound and a pregnancy test. Now, like I said, not all patients are going to have right lower quadrant pain. This can also be left lower quadrant pain because ectopics can occur on either side. Nice. Now, I wanted to, as you can see, I wanted to pop a couple of extra GI causes in there because these are so important as well. Crohn's disease. Which anatomical location does Crohn's disease most frequently affect? Does anyone know? Terminal ileum, spot on. So the terminal ileum, from a surface anatomy point of view, is essentially located around the right iliac fossa. So presentations of exacerbations of Crohn's disease often present with right iliac fossa pain, often with diarrhea, weight loss, fevers, etc. when patients have these flares. So that's really important as well, to take that holistic history, not just about what they've come in with right now, but you think, okay, over the last few months, have you noticed any change in your weight? Have you noticed any change in your stool or your bowel habit, for example, because this may be a first presentation of undiagnosed inflammatory bowel disease, or more specifically, likely Crohn's disease. And then these patients will need, fecal calprotectin, which can help you in your stratification of patients with suspected inflammatory bowel disease, and then a colonoscopy and biopsy is going to be diagnostic. And also hernias. Any patient with lower abdominal pain as well, try and examine that inguinal region. Well, don't try, do examine that inguinal region. Assess for groin masses, lumps or bumps, because there may be an incarcerated hernia or strangulated hernia, which will require surgical intervention. So don't just stick to the abdomen. You do need to lower, with their patient's permission, lower their trousers or whatever they're wearing underneath, lower them down a little bit and examine that inguinal region very closely. Ask them to cough, assess for a cough impulse. They may need to stand to see whether there's any bulges that you've been missing, but do be very thorough because you do not want to miss a strangulated/incarcerated hernia. Brilliant. So still thinking about right lower quadrant pain. We have a 12-year-old boy who's presented to the emergency department with sudden onset severe lower abdominal pain, particularly on the right-hand side. He's vomited twice with this pain and is walking with a waddling gait. Abdominal examination is performed, which demonstrates mild lower abdominal tenderness. What other examinations should be performed to elicit the likely diagnosis? Just in the chat now. Good. Anyone else? So we've got testicular, genital, we've got cremasteric reflex. Spot on, all of you. We need to do an external genitalia exam on this young boy. And why are we doing that? What is the diagnosis we must exclude? Torsion, exactly. Testicular torsion, a urological emergency. The history is strongly suggestive of testicular torsion. If you examine the patient's abdomen, inguinal region, and external genitalia, and you find a tender right testicle, potentially swollen and red, erythematous, and potentially that cremasteric reflex might have been lost as well, you know, this patient needs to be taken straight to theatre. Do not dilly-dally with ultrasounds and things. Get straight on the phone with urology or general surgery, depending on who manages torsions in your hospital, and get them to theatre. You do not want to miss a torsion because you're too embarrassed to ask the patient or the parent, you know, can I examine the genitalia? Because that will result in this patient's testicle becoming necrotic, non-viable, and, you know, absolutely disastrous long-term effects. So do not be embarrassed. Lower abdominal pain, examine the inguinal region, examine the external genitalia if you're thinking about, you know, things like torsion, for example. Hopefully that, you know, that's a really important point that's hammered home. People are asking what torsion is. It's just twisting of the testes on its spermatic cord. That's all it is. You got the spermatic cord which comes down here, you've got your testes here, it twists around. And this is because a lot of these patients have anatomical variants which predispose them to have an increased risk of that twisting taking place. When that takes place, all these vessels which lie very, you know, close to your testes, like testicular arteries, your pampiniform plexus of veins, all of these are going to be disrupted, and your testes becomes necrotic and non-viable. And that normally can take place within 6 hours. So once you get beyond 6 hours, you're thinking, you know, this is really, really dangerous. So we need to get patients as soon as possible to theatre. And this is why we think it's torsion. Severe abdominal pain / testicular pain would be expected on one side only. You know, in rare cases, it can be reported as being bilateral, but once you examine, the pain should be on one side. Vomiting is very common, and children often present with waddling gait as well. So, you know, lower quadrant pain, make sure we're thinking, could this be a torsion as well? Clinical diagnosis, get them to theatre. But similarly, you know, lower quadrants, if we include that suprapubic region in as well, if you palpate there, if they've got some other lower urinary tract symptoms like dysuria, frequency, we're thinking that could this just be a bog standard urinary tract infection? Get a urine dip, pop the patient on some oral antibiotics, and they should be good to go. But of course, get a full set of observations and things as well. Nice, that's right lower quadrant pain. And also suprapubic pain as well, and testicular pain, all kind of mashed up in there as well. Let's think about left lower quadrant pain. Now, once again, the good thing is that, you know, common things are common and emergencies are emergencies, and what can cause symptoms on the right often can cause symptoms on the left as well. So things like hernias can be on either side, ectopics can be on either side, torsions can be on either side, and UTI, you know, I've put it under both because it often causes suprapubic pain, which is in the middle of both of those quadrants. Now, the one thing that has changed on this slide is that inflammatory bowel disease has changed from Crohn's disease to ulcerative colitis. And that's because ulcerative colitis most commonly affects that left lower quadrant kind of sigmoid region. And patients who have a flare of ulcerative colitis, it may be their first presentation of it, for example, often present with left lower quadrant pain and then rectal symptoms. So rectal symptoms like tenesmus or fecal urgency, but then also changes to stools with like diarrhea, fresh rectal bleeding as well. And once again, make sure you take that full history, not just what the patient has presented with. We want to know how they've been over the last few months. Have they noticed any changes to their stool habit, for example? And then in these patients, these patients are going to be diagnosed with colonoscopy and biopsy. In the acute setting, we try and avoid, if a patient's having a massive acute flare, avoiding doing colonoscopies and things because that increases your risk of perforation. But we still treat and try and get some form of imaging done as soon as we can. Good, and that's left lower quadrant, but we also want to think about potentially some other causes of left lower quadrant pain as well. We have this absolutely lovely lady, isn't she? She looks such a nice woman. She's 72 years old. She lives in a nursing home, and her carers call an ambulance as she's developed worsening left iliac fossa pain. This morning, her carers noticed that she had been incontinent of feces, and there was a large amount of fresh blood in her incontinence pads. An abdominal examination demonstrates left iliac fossa tenderness and guarding. Now, do not answer yet, please. Let's answer together over here. Based on that history, which of the following, that's better. What is the most likely diagnosis? That's what we're asking. What is the most likely diagnosis? Good. Diverticulitis. I would agree. Diverticulitis is the most likely diagnosis. And diverticulitis, so as we grow old, we will all develop things called diverticular, which are just small outpouchings of your large bowel, completely physiological, nothing to worry about by themselves. And almost all elderly patients have them. But these little small outpouchings of your large bowel, your diverticular, when they become inflamed or infected, that condition is called diverticulitis. And that can present characteristically with the symptoms that we have described here. So left lower quadrant pain, fresh bleeding in elderly patients. These patients often have fever as well. And this is strongly suspicious of diverticulitis. Patients are often managed, the vast majority can be managed with IV fluids, IV antibiotics, admit under general surgery, monitor. But in patients that are profoundly unwell, if they've developed stricturing disease or they've perforated, they will need surgical intervention. But thankfully, the majority can be managed with IV fluids and antibiotics. Now, a few questions here. I've got some people talking about her colon cancer as well. Now, colon cancer, of course, can cause abdominal pain. It can cause usually occult bleeding in your stool rather than, massive amounts of blood in your stool, but blood in your stool as well. This webinar is really focusing on those emergency conditions. But of course, conditions like colorectal cancer are important to consider as underlying causes of abdominal pain. Why fecal incontinence? Well, in this case, I would say that the fecal incontinence is likely the patient's, their baseline, because if they're wearing incontinence pads, they're likely incontinent anyway. So she's probably been incontinent of feces, and once they're changing her pads, they've noticed this fresh red blood. That's the most likely story here. Patients with diverticulitis are given antibiotics. Not all patients are managed with IV antibiotics, actually, I should say. Some patients can be managed just with oral antibiotics. If they're more unwell, then IV antibiotics would be appropriate. Nice. So then we've just popped diverticulitis there as well. So rectal bleeding, often have a history of constipation as well. That predisposes you to diverticular to be formed, and left lower quadrant pain with fever, and CT abdomen and pelvis with contrast is the diagnostic investigation of choice. Lovely. Last area of the abdomen, periumbilical pain. So we already touched on appendicitis, so periumbilical pain, which then migrates to the right iliac fossa, so the migratory abdominal pain. So we know all about that now. Now, if you look back at our webinar on bowel obstruction, hopefully you remember stories like this. So 60-year-old female, this is directly from that webinar, 60-year-old female, central abdominal pain, nausea and vomiting, which is coming and going, tinkling bowel sounds, and systemically unwell. That is a characteristic history of small bowel obstruction. Now, small bowel obstruction and large bowel obstruction is not always periumbilical. You can get generalized abdominal pain as well, but you know, for simplicity's sake, we often do call it periumbilical, but it can be more generalized. So small bowel obstruction is a really important diagnosis here. So, you know, abdominal x-rays are useful, but really the test that we're going to need is going to be a CT abdomen and pelvis contrast to diagnose it and find a twisting point to see what's caused that small bowel obstruction. So what is the most common cause of small bowel obstruction? Can anyone tell me? Adhesions, spot on, thank you. Well done, Jasmine and Catherine. Adhesions, so often patients will have had previous surgery, which has caused adhesions to form, which then causes a physical, mechanical obstruction to your small bowel, and they present with this colicky pain, which can then become constant with nausea and vomiting, and then later down the line, complete constipation as well. So not passing feces or flatus, and that's what's known as obstipation. Large bowel, sorry, before we go on to large bowel obstruction, these are some important causes of small bowel obstruction. So bowel adhesions, most common cause. This diagram shows an incarcerated hernia, and that's once again why it's so important to examine for hernias, but also other causes like Crohn's disease, volvulus, interception, and ileus. Ileus is a functional obstruction. Good. Now, let's think about our final case here today. Case-based discussion number 10. So we've got this chap here lying in bed. He doesn't look great. He is a 56-year-old male who presented to the emergency department via ambulance with severe central abdominal pain. He has a history of hypertension, type 2 diabetes, 13-pack-year smoking history. Look at those obs. Those obs are not good. Look at that heart rate and blood pressure. Absolutely awful. You know, this patient is on the verge of death, really. And I'm so glad to see straight away in the chat, we're thinking AAA. Abdominal aortic aneurysm. So this patient has likely ruptured an underlying abdominal aortic aneurysm. All an abdominal aortic aneurysm is a bulging out of your abdominal aorta where the diameter has grown larger than it should be, several times larger than it should be. These are prone to rupture. There are screening programs available for men over a certain age to look for abdominal aortic aneurysms, because once they're over a certain size, when they rupture, the majority of patients are going to die. And this patient is tachycardic and hypotensive, very much so. So most like, and also this, his significant history here, you know, all of these cardiovascular risk factors predispose him to abdominal aortic aneurysm formation. And these patients will need to go to theatre. Any patient with a symptomatic abdominal aortic aneurysm needs to go to theatre, even if it's just abdominal pain. They need urgent repair. if it's the rupture, they need like life-saving surgery right now. Because, and also, so my dad is a urologist, so he deals with kidneys and bladders and whatnot. And he told me a story of a patient who they suspected to have a renal stone. As A&E often do, they admitted the patient under urology, said this is a renal stone, we're just awaiting the report to come back. The patient was tachycardic, hypotensive. He was admitted under urology, waiting for this report to come back, and actually it was a ruptured abdominal aortic aneurysm, because like someone with a blank name has said there, lots of AAAs come in with back pain as well. So it's not just necessarily this periumbilical pain, you know, back pain, flank pain, any elderly patient, not even that old, this guy is not that old, anyone middle-aged, elderly, particularly if they are male, with pain sounding that central or flank, with any kind of cardiovascular risk factors, get an ultrasound by the bedside. You know, you may not be trained in getting an ultrasound by the bedside. If you're an A&E, get a real registrar, get your consultant. Just a quick jelly scan of the abdomen will show whether there is an abdominal aortic aneurysm and whether it has ruptured as well. But do not miss this diagnosis, because it's life-threatening, of course. So I've also chucked large bowel obstruction on there as well, and then abdominal aortic aneurysm. So like we said here, kind of flank pain, kind of back pain. Do not wait for them to deteriorate before you manage them, because they will die. So like I said, get that bedside ultrasound. It takes a few minutes to do, and it will help with that diagnosis. And CT angiogram is the test that we really like to have done before we get the patient to theatre. But if you need to go straight to theatre because the patient won't survive CT, then get them to theatre. So that is a rundown of periumbilical pain. I know I've put AAA under periumbilical, but like we said, back pain, flank pain, really important. Don't miss this diagnosis. And really, that is, you know, almost exactly an hour. We have covered an absolutely humongous amount, a huge number of conditions, hopefully split them up into a way which is straightforward for you to understand. So I split them into quadrants because I think that's the easiest way to remember them, but also remembering how we differentiate these conditions, what extra investigations we need to do, you know, and how, you know, which patients need operation or to get to theatre straight away, how are we going to manage these conditions, you know. And I was so impressed by your kind of extra depth of knowledge that you've developed here, not just thinking about diagnosis, but thinking about how can we differentiate these conditions. And that is going to stand you in fantastic stead moving forward. So thank you so much for sticking around till the end. Like I said, you've covered a huge amount. Please do, if you like this webinar, do check out our question bank, our textbook, all our other webinars. We've got tens of hours of webinars all over our platform. I'm so grateful for your kind words. Please do fill out the feedback form. I would absolutely love some feedback, particularly because I've put in some extra videos and things in there. I wanted to know whether kind of that would be useful. So, you know, as I said, so grateful for your support. Please, you know, I love everyone's kind words as well. Thank you so much for all of them. If you, you know, and I know there are people all around the world, this video will be uploaded for free for everyone. There are a huge number of videos totally for free on our website. We unfortunately do not do CPDs at the moment. We're in the process of trying to get them sorted. We are trying to get a certificate scheme sorted as well. I've put the feedback form link in the chat there. And, you know, welcome from Healthy Friends Nutrition from Long Island, New York. Great to have you here today. Big hello from Central London. Hello, Eric from Dublin. Thank you, Ryan. I'll stick around for some more questions as well. I'll also check out the Q&A because I have accumulated some questions. If you have anything else you would like to tell me or ask, feel free. I'll try and look through these questions. So I've answered that, answers that. I have some questions from people asking about their own medical conditions. Unfortunately, I can't answer those questions. Please do contact your GP or a doctor looking after you. I'm sorry, I can't answer those. My texts say that the pain in appendicitis usually originates in the right iliac fossa, then shifts to the periumbilical region. It is the other way around. Yes, so it characteristically starts in the periumbilical region and migrates to the right iliac fossa. Oh wow, the chat is really popping off. Thank you so, honestly, you guys are so kind. I really, really appreciate it. You know, we have, it's been a year which has flown by, and it's so glad to see that there's still thousands of you still tuning in. Let's see if there are any other questions here. First year, what is testicular torsion? Hopefully I've answered that question for you. Does diverticulitis present with blood in the stool, often with fresh PR bleeding? What if these patients present to GP? Get them to A&E, call an ambulance if you need to, get them there. You know, GP for really most of these patients we've talked about today, other than maybe UTIs, for example, should end up in A&E. I mean, the patients presenting with flank pain or back or abdo pain presenting to the GP and their obs are relatively stable. You know, it's hard to say. It's going to be dependent on a case-by-case basis. You know, we call it the end of the bedogram, which is, you know, from the end of the bed, how does the patient actually look? Like, observations are one thing, but observations can deteriorate pretty quickly. If you think this is something which needs urgent treatment in the next few hours, get them to A&E. Once again, you know, people are telling me that they're very, you know, heartfelt stories, and I'm very sorry for, oh my gosh, that's an awful story. I'm so sorry for your loss. Unfortunately, I can't provide information about specific people's or relatives' conditions for indemnity's sake, but I'm so sorry for your loss. That's heartbreaking. I'll just have a look back through the chat. Very informative, thank you so much. Recommended analgesia for abdo pain varies depending on the likely diagnosis. So like renal colic responds very well to diclofenac, so like rectal NSAIDs, for example. Whereas, you know, cholecystitis, you may just give them, you know, work up your WHO pain ladder, basically. So paracetamol, NSAIDs, weak opiates, and then on to morphines if you need to. Where's the feedback link? Sorry, I will I'll put it again into the chat. Otherwise, you can use the QR code. Feedback form is, oh, why isn't that sending? Feedback form is there. Sorry about that. Can testicular torsion present in geriatrics? You know, it's incredibly rare for torsion to present in elderly patients. Much more disease of younger men. So even young children, so it can be pediatrics, it can be men in their 20s, 30s. It can present in elderly patients, but it's much less common. Nice. I think I will call it a day there. Thank you so much from all of you all around the world for tuning in. Stay safe. I think you feel free to use my promo code Azim2021 if you want extra discount or to gain access to everything that we do. And yeah, all the best. And I think, I'm not sure when our next webinar is. Let me take a look. Our next webinar is on the, there's so many, I actually don't know. Take a look at our timetable on Instagram or Facebook. Yeah, I can write a code here. So Azim2021 will give you an extra 20% off for our whole platform. But yeah, thank you so much for the feedback and for everyone's kind words. And please take care of yourselves, and we will see you very soon.